Morning, everybody.
Morning.
Give it a few moments. Get going. Everybody, 2 more seconds to come. I just realized an error. Which is today is the 26th. We know if Christine is joining us this morning.
I'll text her and find out.
Right.
And I think Molly I don't know if she's on, but she has like a doctor's appointment.
No worries. Okay. Let's move forward. Okay, so this is a postop VSD. And I was asked to comment on this tracing. And we have here the tracing with the so-called atriamp. So why don't we ask Dr. Mukhopadhyay what she thinks is going on here?
Good morning, Dr. Paz. I'm looking at the tracing, and
So just so you know, the top is lead 2. The second channel is the so-called atriamp channel.
if I'm looking at lead 2, I can make out the QRS complex, and it doesn't. And if I'm looking at the atrium, then there apparently is a P wave there. I would just assume that's like pointing to a P wave, but I don't see anything which is like gives that like which is evident of a P wave there. It just appears to be a QRS complex, and
Well, which is the QRS? Is it this complex that I'm pointing the arrow at, or this
yeah,
complex?
the first one.
This one, right? So
Yeah,
these two leads are simultaneous, and so
right.
and we know from the surface lead 2, this is clearly the QRS, right?
Yeah.
This corresponds to the QRS. So then the atriamp is doing what? What does the atriamp device do?
It points out where the P wave is.
Yeah, it augments the atrial electrogram
Right.
because the device is literally attached to one of the temporary atrial leads. And so in this particular case, then what is this? If this is the QRS, which I agree with you, it is simultaneous with it. What is this signal?
So this is like pointing to the P wave.
Right. Again, I would prefer you use the term atrial electrogram because you're correct. That is where the P wave would normally follow. But it's essentially, you should think of it as augmenting the P wave by recording directly from the atrium itself, right? So that's the atrial electrogram. So now you know the relationship between the QRS and the atrial electrogram. So the question is, what do you think this is then?
It seems that the QRS is followed by the P wave.
Mm-hmm.
And so I would think this is not a sinus rhythm.
Okay.
And um, so I'm looking at the QRS morphology in lead 2. It seems as if it's a little wide, so I would think it's probably some kind of uh, ventricular rhythm.
Uh-huh. Yeah, okay. That's certainly, I would say, is number one in the differential diagnosis, is that this could be ventricular tachycardia of some sort. And what's happening in the AV node then if there is an A following every QRS? If you're correct that this is VT, and I'm not saying you're not, but if it is, well, how do you explain the fact that there is an A following every QRS?
I guess by the time the ventricular rhythm is generated, and by the time the refractory period is over, maybe there's a P wave which is conducting, which is leading to the formation of the atrial, which is leading to atrial depolarization.
I'm sorry, how is it? How is the P wave depolarizing?
Sorry, I meant that if the rhythm is originating in the ventricle and is leading to a ventricular rhythm,
Mm-hmm.
by the time it's by the time the refractory period is over, then the P wave
Refractory period of what?
of the AV node.
Okay, what does that have to do with anything? If you're in VT, where is the impulse coming from?
From the ventricles.
Okay, so do AV nodes conduct? We
No.
know AV nodes conduct antegrade. Can they conduct retrograde?
Yes, they can also conduct retrograde.
Right. So if you're in a rhythm that's originating from the ventricle, is it possible that it could be conducting retrograde through the AV node and then depolarizing the A retrograde?
Yes.
Yes, indeed. That's what's happening here. Now, as you get older, a lot of people lose retrograde conduction in their AV node. So not everybody conducts retrograde in their node. But generally speaking, most people have bidirectional conduction through their AV node. So this probably, right, is a ventricular rhythm with ventriculoatrial conduction with one-to-one VA conduction. That's one possible differential. Now, how would you know if this is VT or not? In other words, you've just told me that your presumption is it's VT because the QRS is wide, and that's a reasonable presumption. But after a VSD, can the QRS be wide if you're in sinus rhythm?
If you have a block, then you can have a wide QRS.
What do you mean a block?
Like
Use a more
like
precise term,
uh,
please.
like a right bundle branch
Right.
block.
So if you have a right bundle branch block, which is not uncommon following VSD surgery, you could have a wide QRS. Can you tell whether this is a wide QRS from VT or from a bundle branch block from this monitor tracing?
I don't see like an RSR dash pattern. It just
Wow, you can see an awful lot in that microscopic lead 2 there. Would you see an RSR pattern in lead 2 in somebody who has a bundle branch block?
um, I'm really not sure of the answer
I
of
mean,
that.
you might, but do you have any other so the question here is how do you cinch down or how do you confirm this diagnosis? Um, so if you think this is VT and not from a bundle branch block, how would you do this? Like how would you figure that out?
Um, a bundle branch block, I would think would be in sinus rhythm, so there would be a P wave before the QRS complex.
Right. But what other rhythm could this be? If you had a bundle branch block, and let's say there was ventriculoatrial conduction, could this be something else? What about jet? Could it be jet?
Yes, it can be jet.
Right, it could be jet,
Yeah,
right? If your
yeah, yeah,
QRS following surgery is wide, you
yeah,
could have one-to-one ventriculoatrial conduction in jet too, right?
yeah.
So how would you know whether this QRS on this one single lead of ECG on the monitor is your usual QRS that you would see in sinus rhythm or an unusual one in VT? What would you, so you're at home, it's 2 in the morning, the nurse practitioner on in the ICU has sent you this tracing. What is the next test you're going to ask the nurse practitioner to provide for you in order to better know? You see that there's an A following every QRS, but how would you make sure that you know what this is? What other test could you do at the bedside?
I can do an EKG at the bedside.
Yes, you could do a 12-lead EKG. I'm going to give everybody a hint. The answer, get a 12-lead EKG, is never the wrong answer. You can get 100% answer, 100% credit for every question I ever ask about what the next best test is. 12-lead EKG will almost always be the right answer. So yes, you can get a 12-lead. Now, how would the 12-lead help you? Would you be able to tell if there was a bundle branch block better with the 12-lead? Has Katoki lost her microphone there?
No, sorry, I'm trying to think. Like a bundle branch versus a VT, you mean? Like to
Yeah.
differentiate between them?
Can you make a distinction between those two?
Um, I can definitely measure the duration of the QRS complex and
Well, first of all, VT can be coming from anywhere, right? So we know what a right bundle branch is supposed to look like, but we don't know what this VT is supposed to look like. So if it doesn't look like a right bundle on the 12 lead, that's one very good hint that it's not jet, right? And could you do any provocative testing to show that this QRS that we're seeing is either a bundle branch from jet or is VT? What would happen if you atrially pace the patient? So we see the rate of this rhythm is 132 beats per minute. What would happen if you pace the patient at 140 beats per minute from the atrium to the QRS if we were in VT? So you're in VT, or you think you're in VT, but you want to prove it. You want to prove that this QRS is not the usual QRS that one would see in conducted rhythm. If you were to pace the atrium at 140 beats per minute, faster than this rhythm, what do you think would happen to the QRS if this was VT?
if I was pacing it faster than this rhythm
Mm-hmm.
and the AV node is conducting
Good point. Good proviso. Yes, the AV node's conducting.
um then I guess the atrial rhythm should take over versus the
Whoa, whoa,
ventricular
whoa, whoa,
rhythm.
whoa. You're controlling the atrial rhythm. You're right. The atrial rhythm takes over. What does that mean, though, to the 12 lead EKG? I'm hearing a lot of flowery language taking
Did
over.
we
World domination of the atrium. But what does that mean? What happens
it
to the
becomes
QRS?
sinus? Oh, okay.
So you're pacing the atrium. You're now faster than this rhythm. You're
Right,
conducting
that
through the AV
it becomes
node. What will the QRS look like if this is VT? Will it look the same or will it look different than this QRS?
so the if the origin of the rhythm is from the atrium now, then it will become the QRS will become narrower than it is if it's originating in the ventricles. So it
That's
will look different.
exactly right. That's exactly right. And you would need a 12 lead while you're doing this to tell that. So one way to figure out whether this is a ventricular arrhythmia or is jet or would be to pace the atrium at a faster rate, run the 12 lead, and see what does the QRS morphology look like. Does it look like this? In which case, we could say that this is junctional ectopic tachycardia. Or does it look completely different, like maybe a right bundle or a narrower QRS? And this is why having a 12 lead would be useful, because it might not be obvious on one lead. You could try it on the monitor, but it may or may not be obvious. So yes, you would want to pace the atrium at a rate faster in order to see. What we did when I was asked to look at this with the cardiology fellow, who happens to be on the call, is I asked for a 12 lead ECG of this rhythm. And then I asked if we had a 12 lead of the rhythm when the patient first came back from the operating room and was not in this rhythm. And that was also a very effective way of determining whether this was VT or JET, or even, and what we found, in fact, was that this QRS was, in fact, quite different than the original QRS when the patient was in sinus rhythm when they first came back. Remember that automatic arrhythmias, whether they're VT or JET, not uncommonly are not present when a patient arrives back from the operating room. There are many reasons for this, but two of the most important is that both JET and VT in post-op patients tend to be automatic type arrhythmias. And it's not uncommon for automatic arrhythmias to develop over the first couple of hours after arrival from the operating room. And so you always want to get that 12 lead ECG reasonably early after arrival from the operating room, because usually the patient is in an atrial-based rhythm, whether it's A-pacing or sinus rhythm. And that may prove to be a very important document when you are assessing the patient later if things were to change in the rhythm, okay? So is it the thing that should be done immediately upon arrival? No, the nurses should do all their appropriate checks and make sure they have the lines proper and, everything is hooked up to the monitor appropriately and that the sign out has occurred. But one of the first tests that should be done after the usual sign off has occurred and people feel that the patient is stable in the ICU should be obtaining a 12 lead. It doesn't even have to be a 12 lead, by the way. I don't know that it's a great idea to put lots of dirty stickers near someone's new sternotomy, but as many leads as you can practically get is a very important test in anybody coming back from the operating room. What else could this be? Let me ask Ivana. So we think now, we now know that this was VT, but if you're just looking at this monitor here, is there anything else that this could have been, this rhythm, in terms of a differential diagnosis? Certainly, we have figured out now that the patient actually was in VT, but what else could this be? There seems to be an atrial electrogram that follows every QRS. Is it possible that atrial electrogram is preceding every QRS?
Good morning, Dr. Paz. So, of course, my two top differentials in this clinical setting would have been JET and VT, first things first. I think, I would want an EKG to look at the actual PR interval to see the actual length. Perhaps
Well,
first degree.
the exact length on this. That's the nice thing about the HRAP, right? It's very long, right?
Right. So you could have first degree block, but I think it's so much closer to the preceding QRS, it would be hard to suggest that. If I just saw the atrium strip, you could perhaps argue that maybe they're, I don't even know if you call it a supraventricular tachycardia because we're not even that tachycardic right now.
Right.
But something conducting a P wave conducting retrograde as well. But I think that kind of.
So again, remember that, we know how fast SVT should be.
Right.
It's not 132.
Mm-hmm.
But the only point I'm trying to make is that, we naturally assume correctly, based on our knowledge of what happens to people after VSD surgery, that this is almost certainly either VT or JET, most likely JET, second VT, just in terms of prevalence. But when people have VSD repairs, they certainly can get first degree heart block, right? They can definitely have injury to their AV conduction, either at the AV node or the his bundle, or even at the bundle branches. And so again, another reason why getting a 12 lead would be very important because, right, it would not be surprising for someone. I agree with you that when the R to P or the VA interval is so much shorter than the PR interval, we would most likely think that this is a retrograde P wave, but it certainly could be an antegrade. But that could be easily ferreted out on an electrocardiogram because if we were in sinus rhythm with a long PR, right, the P wave should be upright in leads 1 and 2 and F, just like a normal sinus P wave. And so it would be probably very obvious if the person was in sinus rhythm, based on the 12 lead. Again, pointing to the centrality of having a 12 lead ECG. It really can help ferret out a lot of this stuff. We go to the fancy atrial electrograms and AtriAmp. And in this case, AtriAmp was very helpful in showing us the relationship between the ventricle and the atrium, but it does not tell us what the diagnosis is. Okay, so we now have a 12 lead ECG. Let's say that this patient, for sake of conversation, is 3 months old. So we have an ECG that shows that this QRS is definitely different than the QRS when the patient first arrived 3 hours earlier. It is definitely a ventricular. You've paced the atrium at 140, and you've demonstrated that you can narrow the QRS when you're going down the AV node, suggesting again that this is possibly ventricular tachycardia. So you're pretty sure you have VT. So now the question is, you're being told by the ICU, patient's pretty stable. I know that the art line says 53/37, but actually the cuff pressures are routinely 60s/30s. The patient is making urine. They're like, what do you want to do about this? Do you want to treat this? Do you not want to treat this? So what do we ask Dr. Bezdakova? So now you have your diagnosis. You're in some kind of accelerated ventricular rhythm versus VT. And some people characterize one from the other by saying if the rate is over 175, or if there is hemodynamic embarrassment, you would say VT versus accelerated ventricular rhythm. So, Christina, how would you, you're being asked, do you need to treat this by the ICU staff?
So I think, seeing, after we do this workup and evaluation, and we see and come to the diagnosis that this patient has VT, although they're stable, I think, I would understand why the bedside providers and staff would be, more nervous taking care of this patient. But
interestingly, in this case, the bedside staff, I think, was semi-advocating to not treat it. They were looking to us for rationale to treat it.
I think that I wouldn't treat, the patient is stable, and I think this patient has A and B wires still in place, correct?
Yes.
So
we know there's A wires because
yes.
there's an atrium.
So I think that I would be comfortable watching it, and if the patient became unstable, since we have the A wires in place, we can atrially pace if they become hemodynamically unstable.
Okay, I certainly think that is not unreasonable. It would not, however, be my choice, and I'll tell you why. So when people have VT, right, we know in general they're not going to have as good cardiac output as they will in sinus rhythm. Certainly, in this case, we have adequate cardiac output. But when do patients following cardiopulmonary bypass start developing, a bit of a slowing in their cardiac output, a reduction, post-pump slide? When does that normally happen?
Say about between 6 to 10 to 12 hours after surgery.
Right. And so we basically have an adequate blood pressure, which we all know is one of the last vital signs to go down when something's bad. We're making like 1 cc per kilo of urine per hour when we have not yet hit that point where we anticipate that the cardiac index is going to fall over the next couple of hours. So I would not go into an evening or into the period where we're expecting the lowest degree of cardiac output, knowing that we're in VT. Because remember, most of the treatments we would use to treat a low cardiac output are likely to make VT worse, right? Let's say the blood pressure will start to sag, or we felt that the patient had cool extremities, or that the urine output was falling. Some of the things we might use would be either some more inotropic support, maybe add milrinone. All of these agents are actually pro-arrhythmic and might make the patient even worse. So I would say that although in general everybody knows that I'm very much a believer that the enemy of good is better, I would say in this case, one needs to be a little more proactive, because we can anticipate that things are going to get worse, particularly in somebody who is relatively soon after surgery and has not even hit their sort of nadir of bad cardiac output following a bypass run. So you've decided, after talking to me, I'm half asleep, but we have decided together that we are going to treat the patient's VT. So we have a 3-month-old. So what are your options, Christina? I'm dragging you kicking and screaming to treat, even though you're of the mind to watch. And by the way, again, I want to be clear. You could watch this. Is there any non-medical treatment you could use for this? You know, not antiarrhythmic agent that you could use to treat this?
Like atrial pacing.
Yeah, you
And
could
yeah.
remember the primary rule of EP, that whatever is fastest wins. So you could pace at like 145 at a rate faster than the VT and see if you can suppress it. And you would be in you would have AV synchrony, and you would potentially suppress it. Now, what we don't know in any individual patient is whether atrial pacing is going to make the patient better or worse. In other words, VT at 132 might be hemodynamically superior to apacing at 145. Probably apacing at 145 will be better, but we don't really know that. So you definitely would want to, you would definitely want to try it and sit at the bedside for a while and see how it looks. One of the things that you notice on this tracing is that the CVP is very high. So that would also be a reason I would treat this, and was also in my brain as I was looking at this in terms of whether we should treat somebody who has a CVP that's that high, which is likely because you have AV synchrony, would benefit from having AV synchrony. So yeah, you could pace at 145 or 150, but oftentimes in post-op patients who are starting to sag after a bypass run, it's possible that the VT may accelerate as the adrenergic tone rises from a low cardiac output state. So yes, you could start by pacing, but you find that you're pacing at 145 for about 20 minutes, you're great, but then the VT starts to accelerate. So now you have to actually treat it with medication. So what are your options?
So, I think you can give medication such as procainamide.
Yeah, you could give
Especially,
procainamide.
yeah.
That's reasonable. So good
Also,
VT treatment. What else could you give?
beta blockers such as propranolol.
Okay, so
as
we
well.
wouldn't normally give, so propranolol, although it can be given intravenously. Have you ever seen us give propranolol to anyone in a post-op setting who's really sick?
Not in the immediate post-op
Right.
period.
So we're now at the point in our fellowship, getting closer to the end of year 1, that you have to start asking yourself the question, have I ever seen this? Now, you're still young enough that if you haven't seen it, it doesn't mean it exists. But as you get older, you will realize that increasingly, if you haven't seen something, chances are it's because it was not something that anybody thought was a good idea. And when at my age, people start talking about new things or trying something new, if I've never seen it done, I'm very skeptical, because usually I've seen most things that work and also what the things that don't work. It doesn't mean there aren't new ways to treat things, and I'm always excited by that. But the point is, you have to ask yourself, have you ever seen us say, give 1 milligram of propranolol IV stat? No, we've never done that. One of the reasons we don't do it is because, first of all, beta blockers don't work very well for VT, at least acutely. And we try not to give IV propranolol because it can be very hemodynamically embarrassing. I would recommend strongly that unless you're on a desert island and it's the only medicine you have, do not give IV propranolol or labetalol. It can be very dangerous.
Okay.
But what is there an IV beta blocker though that we could use that is a little gentler?
Sodalol?
Okay, that's is sotalol a beta blocker exclusively?
No.
What is
And
sotalol?
then it's also a
What class does it have in there? It
it
also has a
is
class 3 agent, right? So
yeah,
it's a
it's
beta
also a
blocker and class 3. But yes, IV sotalol, I'll give you full credit for that. Although I'm going to take a point off for calling it a beta blocker, because although it is a beta blocker, it has other effects as well. So
mhm,
IV sotalol would be something you could try, although there's not very much evidence of its efficacy in this setting, but it might be effective. It's just a relatively novel agent, not as much data
yeah.
about it.
And
Uh,
then
what other
you
beta blockers could you use?
um
Could use esmolol, right?
yeah.
Esmolol is used like water at the Children's Hospital of Philadelphia, my friend Chris Jansen tells me. Although again, not sure I would treat VT as with my first agent as esmolol. So I like your first choice the best, the procainamide. Is there any other agent that's probably more commonly used to treat this?
We use amiodarone.
Could use amiodarone. That's a very popular agent that could be very effective. What would be the downside of using amio in a 3-month-old?
It can be hemodynamically can cause hemodynamic instability
Right, can cause
or blood
hemodynamic
pressure. So
collapse because of we believe because of the diluent tween 80, which is an alcohol base that can, in a idiosyncratic manner, cause cardiovascular collapse about 2 or 3% of patients. Although interestingly, we learned on rounds last week that you can order amio that does not have the alcohol base. Apparently, if you order it in the bag that's pre-made, it does not have the alcohol base.
mm,
So the only downside of it is that if you want to give a load from the bag, you have to give a larger volume of amio. If they get it out of the vial, then it has the alcohol base. I didn't know that, but it's a nice little clinical pearl. I don't know honestly if that makes a difference, but it is theorized that it is the alcohol base that causes the cardiovascular collapse. So we could have used amio. Downside is that you're taking a small risk, small but very real risk of cardiovascular collapse in a patient who's basically doing okay. And then what about any other agents for VT that one could use?
yeah, and then IV lidocaine as well
Right,
for
you could use lidocaine, um, which has the benefit of not having as much hemodynamic impact. So procainamide usually causes vasodilation, so you have to be ready to give volume if you're using that. Amiodarone can cause cardiovascular collapse and hypotension and is a very potent negative inotrope, so you have to be ready to support someone like that and also be ready to turn it off if you see something untoward. And lidocaine is kind of a weak antiarrhythmic agent, but it may be effective in treating VT and carries relatively small amount of side effects. The most important ones are usually neurological ones. Patients can seize from high doses of lidocaine. And if you give lidocaine to a patient who is awake, they will often tell you they have paresthesias, and sometimes they see colors, and they can have pretty much any neurological symptom at almost any dose. So that's basically, you could use any of those treatments and then atrially pace. In other words, if you can get the ventricular rate to come down and stay down, you could apace, and then you'd have AV synchrony, and you would have a control of the rhythm underneath. And we did some combination of all of that in getting control of this rhythm. Any questions about this case? Is it useful to, in the past, I've done more slides in the same talk, but I thought it's useful sometimes to talk a length about one case. Is that, you guys find this of use, benefit?
Yeah,
Yeah.
definitely.
Yes.
Okay. All right. I think with that, we'll stop for the day. Hope everyone has a wonderful day. Thanks for joining.
Thank
See you. Actually, Thursday, we have angio rounds this week. Okay. Take care, guys. Bye.
Bye.